What is ARDS?
Acute respiratory distress.
All right, acute respiratory distress syndrome. It is a very generic umbrella term for your patient is not
Okay.
they're not okay. They're having some respiratory distress to the point where things went real bad. Okay. It can be a result of any kind of like trauma, inhalation, burn, something bad happened to your lungs, and your lungs said something is wrong, and you vasodilated, and that caused you to have increased capillary permeability, and then you leaked into the third space. Where's the third space in the lungs? No. Sorry, in the alveoli. So then their alveoli is going to start to fill with fluid. That is bad because that's where gas exchange happened. And then I was like, oh, but we haven't fixed the problem. So I'm going to keep filling up with water and keep filling up with water until your whole entire lungs are filled with fluid. Yeah. And then that's bad. You're going to be in distress, respiratory wise and acutely. Yes. So then what happens is you've got all that fluid in there, okay, and then your lungs are going to get very fibrotic. They won't move anymore because it's like, no, wait. Okay, so if I can't open my lungs and they're filled with fluid, how do I get oxygen down in there?
You don't.
Oh, this is so terrible. So ARDS is a really big deal, and it's a complication from lots of different injuries. This could be from pneumonia. We have this a lot in COVID. Inhalation burns, like if someone's in a house fire, this happens a lot. So this is something very bad happened to their lungs. Their lungs were like, and then we progressed all the way through. That's what ARDS is in a nutshell. Okay. So biggest risk factors. Number one is smoke inhalation. If somebody's been in, and y'all remember, oh no, you don't know because I'm taught you, in burns, they look perfectly normal. Everybody does. And you're like, oh my God, you look fine, go home. Within 24 hours, they'll be intubated, sedated, and near death, right? Because the inflammatory process takes time. So even if they're up and talking to you and perfectly like looking fine, we will prophylactically intubate them. Okay. Because we know that in 24 hours, their airway is going to be completely shut and their lungs are going to be filled with fluid. This is very hard to explain to patients and family because it may be the dude's like, hey, I'm just hanging out. Oh, yeah, just, a little house fire. No big deal. And then you're like, yeah, we're going to have to sedate him, intubate him, and put him in Burns ICU. And the family's like, why? We don't want to do that, right? Yeah. So smoke inhalation is a big one. Sepsis is a big one because what is sepsis? Infection of the blood. Where's your blood?
Everywhere.
Everywhere, including the lungs, right? So sepsis can cause ARDS. Pneumonia, because pneumonia leads to sepsis, which then leads to ARDS. Yes. Any kind of lung trauma, right? Anything that can happen can lead to ARDS. Aspiration can do that too, depending on what you aspirated, right? But that can lead to it too. And then COVID was a big one for ARDS, and somehow they didn't know how to treat it. And I don't understand. We've been dealing with ARDS for a very long time. And then COVID hit, and then they were like, I do not know. It's so anyway, so the clinical criteria. So if ARDS is a big umbrella, like blanket statement, then I need to know when I can diagnose my patient with it so I can start the ARDS protocol, right? So there are 3 clinical criteria. Number 1,
Fluid in the lungs?
acute. It's happening
right now.
And something bad has happened within the last week. Okay. Because you can have a complication of like, maybe you had a patient that was ventilated 3 weeks ago. They got better. They got out of the hospital and then they developed a pneumonia. That's not necessarily ARDS, right? This would have to be whatever the insult was happened within a week to call it acute respiratory. Okay. So 1, acute onset within a week of the clinical insult. Number 2, both sides of the lungs have to be, we'll call it, do y'all remember what it's called when you have pneumonia and you look on the chest x-ray? They will call it, no, whiteout is ARDS, huh? Either consolidations or infiltrates. So if there are bilateral pulmonary infiltrates or bilateral pulmonary opacities, and you can't explain it by like something else, like, oh, I knew the patient had pneumonia or what have you, like it's starting to fill with fluid and it's on both sides, but we're like, hey, it's just, I guess a sequelae of an injury, then that's clinical criteria number 2. Okay, so number 1, acute onset within a week. Number 2, bilateral opacities or infiltrates, whatever you want to call it. Okay. Number 3 is you have an altered, let me see if I can figure this out. Altered PaO2 to FiO2 ratio plus PEEP or CPAP greater than 5. So let's break it down because y'all know what this means. It just sounds scary. All right. So an altered PaO2 or FiO2 ratio. So PaO2 in an ARDS patient would be very low. So they would need a higher FiO2. Yes? Okay. And they also need PEEP. What is PEEP? Positive end expiratory pressure. Who do we use PEEP on? They need pressure because their lungs are stiff. Okay, so if they're requiring an extra FiO2 plus PEEP, or they're requiring CPAP, maybe they're not ventilated yet, right? Of greater than 5. So PEEP and CPAP, you're going to kind of see similar numbers for. If that's the case, so there's 3 criteria: acute, bilateral opacities, altered PaO2, FiO2, and they need PEEP and or CPAP. Then we're like, it's probably ARDS. Do you understand? Okay, so walk me through the path, and we're going to go all the way down to the end of what we want to prevent. So, number 1, what happened to your patient? Something is wrong. So let's say it was smoke inhalation. They were in a house fire.
Inflammatory.
Okay, so their body says something is wrong. Okay, so there's going to be damage to the pulmonary lining. So obviously when you breathe in smoke, it's chemical exposure, it's burning, it's all these kind of things, right? So your body knows something is wrong. You're going to increase in capillary permeability. You're going to leak into third space. The third space of the lungs is alveoli. Okay, so the first stage is what we call the wet response. Sounds gross. Okay, but the actual name for it is acute exudative response, because what's an exudate? Something weepy and wet, right? So it's going to get wet first, then it gets dry, right? So all this fluid is going to come into the lungs. Fill the alveoli with fluid. Can we gas exchange? No. This is what we call SIRS. What is SIRS?
Systemic inflammatory response syndrome.
Yes, systemic inflammatory response syndrome. Another blanket term for systemically your body is like, oh, something is wrong. We vasodilate and yada yada. Okay, if SIRS is also going to be the beginning of sepsis. When we do our sepsis shock mods lecture, that's where it starts from. So basically your whole body knows something is wrong, right? So what's their blood pressure going to look like? They're going to have very low blood pressure. Yes. Okay, and they're going to start leaking into the third space everywhere. So if I gave that patient fluids, what would happen? Yeah, so they'll still have hypertension. It's going to go to the third space, right? That's really bad. What could I give them if that happened? Albumin to bring fluid into the vessels. Then I'm probably going to have to give them some Lasix to kind of get rid of that extra fluid. Okay. So when their lungs are like, something is wrong, and they're leaking into the third space, right? But before that happens, right before something is wrong, your body recognizes and automatically vasoconstricts, just like if you cut your finger. It's going to vasoconstrict for a minute first, and then it's going to start opening capillary permeability, right? So your patient may have pulmonary hypertension, which will lead to pulmonary edema, correct? Okay. So now your lungs are starting to fill with fluid. We're going to get what's called a VQ mismatch. What does that mean?
Ventilation over
ventilation. Okay, so the V stands for ventilation. The Q stands for it is perfusion, obviously. Perfusion, okay? So in these patients, which one are they doing? Why is there a mismatch?
They have a ventilation problem.
They're still ventilating, but they're not perfusing very well, right? They're able to somewhat get air in, but not to gas exchange. Does that make sense?
Yeah.
So they are ventilating, but not perfusing, which is going to lead to, what does perfusion mean?
No.
They have blood flow, but they can't get oxygen to the tissues. So that means that the patient has hypoxemia, right? Which will eventually lead to hypoxia. Oh, which, by the way, we never answered that question. How can you tell a patient has hypoxia?
What?
We never did answer it. How do you know a patient has hypoxia? Remember we talked about hypoxemia? You would know because of the PaO2 and the SpO2. We never did finish it because I had to go back to the basics. So, do you know? Can we know? Hypoxia means there's not enough in the cells. Can you go into every single cell and find out? No. So there's no clinical way to determine hypoxia. You can do restlessness and anxiety. It would have to be off of clinical signs and symptoms. We got it? It wasn't a trickster. No, that's just real. Okay, so now the lungs are filled with fluid. Okay, so since there's so much fluid, your body says, I need to not make any more of the liquid that I usually make in my lungs. What's the liquid that's normally made in your lungs? Surfactant. So your lungs are like,
no more.
I'm not going to, no more of that. It's already very liquidy, okay? And what is surfactant?
It liquefies the lungs, or the
jam.
DW whatever.
WD-40 of the lungs, so it keeps them nice and slippery, right? And it helps them to be able to open and close, right? Well, if there's no surfactant, right?
Yes.
Okay, so at that point, there's really not a VQ mismatch anymore because they're not
ventilating
and they're not perfusing. Do we understand? Okay, so that's bad, yeah? Okay, so that's the wet phase.
Yeah.
Then we're going to go into what we call the dry phase, okay? Also called the
Fibrotic phase?
fibroproliferation phase. Okay, dry phase or stiff phase, because it's still basically filled with fluid, but we call it's just stiffened and it's like nothing else is happening. Okay, so your lungs are filled with fluid and now they're stiff. That's bad. So your body is going to make fibrin. What is fibrin? Yeah, it's like clotting material, that stringy stuff, right? Okay, but it makes you where your lungs can't really expand because it's like a spider web. So it's be like this. Okay. And so fibrin will go in. What's its job? Huh? It can hold things together and it can clot. So the fibrin, like, think of it as a big spider web. It's going to go around your alveoli and go around your bronchioles, and it's just going to kind of like, choke them. Okay. So that is going to destroy your alveoli. That is going to destroy your bronchi. This is bad, y'all. And now your lungs won't move. So at this point, if I did a chest x-ray, what would I see? White. It's just filled with fluid and fibrin.
Got it.
Spiderwebby liquid. Do we understand? Yeah, that's bad, y'all. So ARDS will lead to
Sears.
No, SIRS led to ARDS, and then ARDS will lead to
Sepsis? Wait, I'm confused.
There's no way you can be confused. This is the most simplest question I could ask.
Sorry, huh?
Acute respiratory failure. Yes? Because at that point, if you're not gas exchanging, you had one job, right? To gas exchange. If you fail at that, then you go into ARF. I hate that. It just sounds like a dog. Yeah. All right. So how do we know they're in respiratory failure? I already told you. I've given it to you today. Very clearly.
Is there O2
PaO2
versus the FiO2?
No. We went over it at the beginning of the session.
Those are 60.
PaO2 less than 60 with a PaCO2 greater than 50. Remember we said you had one job and they failed at it?
Yes.
All right, then. So that's bad. So now you're in respiratory failure. Even ventilation may or may not help, right? Because how do you push air into a water balloon?
You can't.
I mean, you can, but it's not going to do a real good job. So a lot of people end up dying from ARDS because we just can't get rid of the fluid. How do we get rid of the fluid, though? What do you think we need to do?
There are some people.
Oh, stop it. It's inside the lung, y'all, huh?
Oh.
Yeah, we're going to give massive amounts of basics. Okay? Do you understand the basic patho of ARDS? Okay, so now we're going to fix it. Okay, so let's talk about our vent settings. So let's say we have to ventilate this patient, obviously, because they cannot gas exchange. I mean, their x-ray is white. Indeed. Okay, so our goal is to get rid of the fluid, get their oxygenation back. Yeah?
Yeah.
All right, but let's talk about their vent settings because I don't want to mess up anything on this patient, right? Okay. How much VT do you want to give this patient? It will probably be less than 500. So the VT is the tidal volume. Are they with fibrotic lungs that don't move? Are they going to be able to accommodate 500 of a tidal volume? No. What do you want to do for their PIP? What is the PIP? Peak inspiratory pressure. You're going to keep it low too, because what happens if I put it too high? You're going to blow a lung. Yeah? And that would probably complicate things. Where all that fluid going to go? I don't know. Probably not our best way. All right. What about our PEEP? Do they need PEEP?
They need some.
They definitely need some PEEP. We're going to titrate it to, what's the first number we're going to start out with usually? 5. Okay. We never want to go over 10. 60 is your big light, but they're never going to be able to tolerate that. You would have blown that way long before that. Okay. So people just titrate to get the oxygenation, like the bare minimum oxygenation that we need. Okay. FiO2. What do you want your FiO2 to be? No, it has to start at 40, remember?
Oh, so okay.
Less than 60, but probably somewhere around 40. Okay. And your PCO2, where do we want that to be? PaCO2. That's not a vent setting, but it's like a how we're monitoring to see if the ventilator is working, because we not only have to have good oxygenation, we also have to have usually a good range of CO2. But in this patient, we're going to do what's called permissive hypercapnia. We talked about this before, right? What is permissive hypercapnia?
You allow the CO2 to be a little elevated.
Why would you allow the CO2 to be a little elevated?
I feel like the water wheel isn't working like it should, so is it hard to get this?
It would be very hard to get the CO2 out. And at this point, since they have severe hypoxemia, it's probably better to get the oxygen in and just to let the CO2 kind of react to the oxygen. Does that make sense? Okay. Because there's really not a whole lot I can do to force out the CO2 if I cannot move the water wheel. That was a good way to say it. Okay. All right. So ARDS, we said, can lead to, and how do I know they're an ARF? So I need to be drawing serial ABGs and looking for that. Yes? Okay. You need to be listening to your patient a lot. What do you think you'll hear? I mean, you probably won't even hear like that because it doesn't have anything to crackle in, right? Because crackles mean there's like a mixture of water and air, and that's why you're hearing crackles. So maybe you're like, oh no. Well, you still have to auscultate them, okay? Okay. All right. So we are probably gonna, I mean, they're intubated at this point for the most part. Yes? Okay. Your patient's pH, since we have permissive hypercapnia, what do you anticipate their pH is going to look like? It may be a little on the acidic side. So we don't want them to go below 7.3. Okay. So they're going to be somewhere between 7.3 and 7.45, but we're not going to panic. If they do go below 7.3 though, then we'll have to give them more. Well, it's not going to work, but we'll have to give them bicarbonate, right? Because you understand what I'm saying?
Yeah.
Okay. All right. So let's talk about meds. What do you want to give this patient? We're going to give some pretty good diuretics. Yes? Okay. And then what do we want to give to help pull that third space fluid in? How do you give albumin?
Okay.
That was a pretty easy ID. Okay. Since this all started with what? How did all of this start? Right? That happened like, which formed a inflammatory response. So I want to give them corticosteroids before day 14. Okay, if we wait 14 days or more, it's probably not going to be effective anymore. You done already missed your window. Okay, when they're on corticosteroids and they're vented and they have ARDS, what is our big thing we need to watch? Blood sugar, because it can be massively high. So they may need to go on sliding scale insulin for a period of time. If they develop a secondary bacterial infection, which most of them do, can you imagine dealing with ARDS and pneumonia and all at one time? Then they'll probably need antibiotics. But antibiotics don't clear ARDS. You're clear on that. Yes. Okay. How do you want to position your patient? Prone. Oh, she yelled it. Prone. Why do we prone our patients in ARDS? It shifts the fluid to the bottom, the front, so they can breathe better. Yes? So all your patients should be prone. Their head's going to be to the side with a ventilator in their mouth. Understand? All right. Since we're rapidly shifting fluids here, there, everywhere, what is your other concern here? Electrolytes. We have to watch electrolytes very, very closely. Okay. Now I'm going to need an art line and I need to do serial ABGs. Yes. Do they need fluids? Some fluids, but why would we not want to give a lot of fluids? They're already like in fluid volume overload of the lungs. So you can give some if you have to. Okay. Which we probably will have to give some because they probably have hypertension. Yeah. But you don't want to give too much because it's going to flood the lungs. Okay. All right. Do you want to feed your patient? Yes. What kind of feeding? Enteral nutrition. Yeah. We want to do that within 24 to 48 hours. Otherwise, what will happen?
They'll start
We've got
shunting.
like 120 kids. Huh?
They'll start shunting.
What did I ask? As soon as I looked over, I lost it.
What will happen if we don't feed?
Oh, if we don't feed. So the blood will shunt away from those organs, our gut will die. And then I can't fix that, right? Because they're going to get septic and they're going to die of something else, right? So don't do that. So we're going to do enteral feeds. Yeah? Okay. Do we need to restrain our patient? If at last resort, but they'll say like distraction before restraint. How are you going to distract someone that's like, oh, look over here, bubbles. You know, I don't. Anyway, all right, we're going to initiate what? On this patient. Go down your plan of care. We're going to initiate because we ventilated them. So the VAT bundle. Oh, I don't know if you just said that. The VAT bundle. Okay, very quickly, what's included in the VAT bundle?
Elevate.
Elevate the head of the bed, but this time we're going to prone him. Huh? Good oral care. Q 4 hours with chlorhexidine. Turn, cough, debrief. NG tube dissection. Prophylactic peptic ulcer disease. Prophylaxis. I said that already. DVT prophylaxis. Yes. TED hose, SCDs, heparin, Coumadin.
Suction as needed.
Suction only as needed. Sterile. Not scheduled. Eh?
Yeah.
Okay. What is the best indicator of this patient's fluid balance? We're still going to do a daily weight, but we are going to do very strict eyes and nose. Okay. Mobility as soon as possible. Some people are going to be ventilated and still awake. I cannot stay. I couldn't do it. I'm like claustrophobic, so I'd be like, that ain't gonna happen. Just let me sleep for the next 2 weeks. And ventilation care. Y'all know how to do that. Like clean their mouth and yada yada. That's something separate. All right. So do you understand basics of ARDS nursing care? Yeah. Easy enough. And then you're gonna monitor for ARDS. And if that happens, then well, we may end up trying. What? If they get ARF, then we may end up trying because the ventilation didn't work. So
Oscillator.
we may try an oscillator, or we may probably end up with ECMO. Okay. All right.